All right, it is 11 o'clock in Mississippi, Louisiana, 10 o'clock in Texas, and 12 o'clock here in North Carolina. So let's go ahead and get started. I am excited for the September weekly or Wednesday webinar from CHAMPS presenting Building a Baby-Friendly Task Force. This webinar is being recorded so that you can go back and listen at later times or share it with your friends and colleagues. So the quality of the recording is particularly important. We ask that if you need to mute your line, push *6 and unmute again by pushing *6. Please do not press hold. If you press hold, oftentimes we hear hospital background music or recordings, and as pleasant as they may be, it means that we cannot hear one another trying to talk on the line. So please go ahead and mute yourselves by pushing *6 as we go ahead and get started. Today's presenters are Laura Burnham and Emily Taylor. I am Emily. I'm the Associate Director for Hospital Improvement here at CHAMPS. And Laura, most of you are very familiar with Laura. She's your project manager. And we are really excited to be working with all of you in improving breastfeeding outcomes and the equity in maternity care practices throughout Tennessee, Mississippi, Louisiana, and South Texas. As we're getting started, just want to remind everybody again to please make sure that you are muted so that we don't hear any talking or puppies or pagers in the background. You can do that by pushing *6. Our objectives for this webinar, by the end of this webinar, participants will describe the purpose of a baby-friendly task force, list the people to include, and describe best practices for operating as a task force. So let's start very first thing first. What is the purpose of the task force? Why not just operate every person for him or herself and get it done? Laura, I'm going to ask you as the host to try to just mute all participants so that we aren't hearing interruption, please. So the first purpose is to provide a structure for change management teamwork. We know from many, many years of doing this work of quality improvement and more than 20 years of working on baby-friendly in this country that having a structured approach for change management is very important. We also create a task force in order to build facility-wide investment in the project as appropriate. So of course there are going to be some people in your facility who really need to know very, very little about your quality improvement around your maternity care practices and your equity work in breastfeeding. But it is important that the entire facility has some level of awareness, more or less as appropriate to their role. By including people in the task force, oftentimes who you may not see immediately as being important integral parts, they're able to identify their particular investment and what their role is. Many of you who've been on the breastfeeding scene for a while will remember that Regina Benjamin, our Surgeon General, told us that everyone has a role to play in making breastfeeding work. It's the same thing in your facilities. Everyone has a role to play in helping you to improve your practices for mothers and babies. We also want to ensure effective communication across groups. Many times the communication within a particular department, like labor and delivery or postpartum, will be really nice, but it's hard to have communication between, say, prenatal clinics and postpartum. So by bringing together everybody into the task force, it provides an opportunity to make sure that communication is ongoing and effective. It also helps to promote continuity of care for those you serve, again, helping to establish a baseline of philosophy and understanding of the practices so that you're all able to reflect on what has just happened and to provide anticipatory guidance about what is yet to come for your patients. Having a nice, diverse task force helps to ensure the inclusion of various perspectives and styles, which I think is really great. Oftentimes there are ideas that I never would have had doing something by myself, but working as part of a task force, as we do with the CHAMPS faculty, we really get the opportunity to think of things in different ways. And that's really exciting and important to this work. And then perhaps for many of you, most importantly, having a task force helps you to divide the tasks strategically. Oftentimes in this work, whether you're just looking at implementing a few of the practices or you're looking at becoming designated as a baby-friendly facility, It's really important to be able to break it down step by step so that you're sharing the responsibility and that the most appropriate person is working on the tasks for that job. The participants. So who should you include on your team? Well, there are 3 different ways that we'll think about this. First and foremost, you're going to start with your core improvement team. These are the people who will be most regularly involved in the work of your improvement in your maternity care practices. You may then also divide the work into subcommittees, which we'll be talking about in just a moment. And then throughout the course of your work, you'll certainly need to engage people sort of ad hoc or as needed. For example, when you are working on skin to skin, the active involvement of your anesthesia department will likely be very important. If you are looking at adopting a training program for your staff, involving the nurse education or the continuing education department will likely be very important. But those people may not necessarily need to be there for every single meeting. So that's why you have these 3 levels of core improvement team, subcommittees, and ad hoc team members. Many of you who are CHAMPS facilities are familiar with a document that's been shared with you as part of getting started called the CHAMPS Team Roster. That's a great document to use as you're getting started in populating your team. You can almost use it like a checklist. As you're listing out each of the people on that roster, you're thinking about, have we really interviewed them, informed them about what this project is all about, and engaged them in the task force. The first person that you'll need to identify is your CHAMPS or baby-friendly team lead. This person should be a dynamic and organized leader, someone you can count on, and someone who really has the trust of other team members. This person may seem like an unlikely leader. Maybe they're a director or a manager, and maybe they're not. The important thing is that they have the ability to manage the improvement process, and they have the trust of the team and the respect of the team to move forward. So as you're thinking about who will be leading your team, it may be one of the people on this list or maybe somebody different. Of utmost importance is including your nursing staff. So most particularly, you want to make sure that you have the managers from labor and delivery, mother, baby, or postpartum. You want to make sure that you're representing both day and night shifts. Oftentimes we find that our practices look different at night, and when we ask the night staff, they say, well, no one ever told me about it, or I didn't get training on that, or no one ever actually showed me how to do it. So we need to make sure that we have some representation of people who can really speak to the experience of night or even weekend staff members. Nursing management and, of course, your nurse educator will be very important, again, as you are working on staff training for your nurses. It's entirely likely that you will want to include your lactation staff. I know many of you have lactation consultants on staff. They, as the content area experts in breastfeeding, will be very, very helpful, especially as you're looking at steps like step 5, breastfeeding assessment and instruction, or supplementation. But it's important that the entire staff doesn't just revolve around, or the entire team does not just revolve around lactation, because this is not just a breastfeeding project. This is a maternity care project, and we know that the 10 steps, though we call them the 10 steps to successful breastfeeding, are actually critical for the optimal adjustment to the extrauterine environment of all newborns. So for that reason, involve your lactation absolutely, 110%, but avoid the temptation to really let it rest squarely on their shoulders. It's also important to have physician team leads, preferably from obstetrics and pediatrics. And just because it says OBGYN, it may be a family practice doc who does a lot of obstetrics. It may be a midwife. It's just meaning obstetrics, so that you have someone really there who's working on the prenatal education, who is there to help support the process of skin to skin, and also providing that interconceptional support and that postpartum support if mom comes back with any clinical issue. You'll also likely need to include other hospital managers. I strongly recommend right from the very beginning that you include a manager or liaison from any affiliated prenatal clinics. This is very important. Oftentimes you say, people make their decision to breastfeed before they ever even walk in the door. So exactly, that is oftentimes the case. Sometimes they change their minds, but they get very important preparation and support to know that breastfeeding is possible and it is important and there are steps they can take to be successful. So for that reason, from the very beginning, you want to try to include a manager or liaison from your affiliated clinics. And then, something maybe you have or have not thought about is the importance of including a community or patient representative. By involving a community or patient representative, you have a unique exposure to their experience of what it's like, what are they hearing in the community about your improvement efforts, what's the reputation of the facility, is there backlash in the community, is the community happy? As a patient, did they feel adequately supported? Did they feel pressured? Did they feel that they got great education from particular people? Having these community and patient representatives is incredibly important to your facility success. And for the community members, it's a wonderful opportunity to be engaged in the improvement process and really take that back as part of their work and as community members in trying to better the health of their entire community. They have incredible value, so please make sure that you include them. And then as Laura's going to talk about, since you're involving some of these people who will be coming from outside, like prenatal clinics or community and patient representatives, you're going to want to make sure that you actually make it feasible for them to be included. Otherwise, it's just sort of a token gesture. Other ad hoc members may be the NICU manager, a nurse educator, the director of continuing medical education, IT or EMR for when you're trying to work on your documentation. Many of you who are based in facilities have spoken with me already about your clinical documentation. Purchasing, especially if you are trying to become a baby-friendly designated facility, you'll need to work with purchasing on determining the fair market value of your infant feeding supplies and going ahead and making that order. If you have a patient education or health literacy department, they can be very helpful in making sure that the educational curriculum and materials that you're using are the best available, that they're readable in the languages and level of literacy that your patients need. Marketing and public relations can be wonderful ad hoc members, especially as you're doing community events like baby showers, or you want to let people know about great progress that you've made or events you've got going on. Medical billing. Finally, more and more we're able to bill for lactation services. So it would be important that your medical billing is involved in making sure that you're adequately reimbursed for the services that you are providing. There may be other community groups, WIC, La Leche League, infant mortality alliances, any of those groups may be important. And then, of course, as I said earlier, an anesthesia champion, especially for that skin-to-skin work, and often also for cesarean, really making sure that moms are alert and able to respond to their babies, preferably not too numb, so that they're able to have a really enjoyable and impactful experience of skin-to-skin. So just again, I want to emphasize a word on team lead. We encourage you to think outside of the box. Many of you will have had one person championing participation in CHAMPS or breastfeeding or maternity care practices for a long time. And so they may seem like the likely team lead for your breastfeeding task force, your CHAMPS task force. That may or may not be the case. You want to really think through, is this person a great communicator? Are they an influencer? Can they serve as a mentor? Do they really take responsibility and follow through? Are they motivated to do this work? Do they have the support they need to do this work? So you really want to think about who this person is as you're selecting the team lead. Now, you may go into your first task force meeting without having identified a lead, and you may actually have this as a discussion to decide who you want the lead to be, and maybe you share that role a bit. But really do think about the different requirements of your lead as you're selecting the person to take on that role. As I stated before, you'll have your core improvement team, but oftentimes in the work of improving maternity care practices or becoming a baby-friendly designated facility, hospitals have found that it actually helps to break things into subcommittees. The most frequent way that this happens is that the core improvement team meets monthly and then divides into subcommittees that may communicate more frequently via in-person meetings, via email, however they need to communicate, but that they break down the areas of work in ways that make sense. So you may have one policy subcommittee that's working specifically making sure that your infant feeding and care policy is evidence-based and in line with the program, and also that any other policies you have in the hospital about infant care are in line with that main infant feeding and care policy. You may have another subcommittee, and I should say in parentheses here are the steps. So staff training is step 2, that's why there's a 2 there. You may have another subcommittee that's really focusing on the staff training, which may consist of a nurse educator, the CME manager, champions, and training people who will be actually leading this training work, perhaps managers from the various departments. But people who can really help spearhead the development of the curriculum, implementation of the curriculum, and ensuring successful completion by your staff members. Again, that is an area where you want to make sure that the fields who are being trained are also represented on that subcommittee. So if you're looking at training nurses, doctors, and non-clinical staff, you'll want to make sure that you're including nurses, doctors, and a non-clinical staff representative. Then there are, of course, the practices. So these are steps 4 through 9 in the 10 Steps to Successful Breastfeeding. This is where we really focus on the practice improvement, the workflow, and the habits, the routines that we're going through on a day-to-day basis. This is the skin-to-skin, the breastfeeding instruction, the supplementation by evidence-based, the rooming in, the feeding by cue, and the avoidance of bottle tops and nipples without any sort of indication or counseling. So a team that's really working on the ground to make sure that these practices are improving may be a likely subcommittee. And then it's entirely likely that you would like to have a subcommittee dedicated specifically to continuity of care, steps 3 and 10. So step 3 is ensuring the inclusion of all required topics in prenatal care, making sure that moms hear about the importance of breastfeeding and exclusive breastfeeding for 6 months, and that they know about the practices they can do to get off to a great start. And then, of course, from the very beginning, we want moms to know that once they do start with breastfeeding, they're not alone. They're going to have lots and lots of support available to them at the hospital, and then after they're discharged, both from the hospital and in the community, as represented by many of you community members on the call today. So step 10 is making sure post-discharge support is available above and beyond referral to a pediatrician, making sure that moms know where to go if they have questions about how to feed their babies, if they maybe have a support group or a breastfeeding action group, a club. So continuity of care, the components that really happen branching in and out of the hospital and the community may be a logical subcommittee. I'm going to stop there. Now we have really talked about the what. What is a task force? Who's likely to be on that? What does it look like? And now I'm going to turn it over to Laura, who is going to start talking with us about more of the how. How should your task force be created, and how can you sustain it so that it's maximally effective and a positive experience? So Laura, I'm going to turn it over to you.
Thank you, Emily. That was great. I think you gave everyone some really great information about who they want to involve in their task force and the different roles that all the task force members can play. So like Emily said, now I'm going to be talking about some of like the best practices for your task force, so how your task forces will operate. So the different subjects we'll go over is the first meeting that you'll have, then what every meeting should include after that, and we'll also review kind of how to set your goals. So the first meeting. So you should try for your first meeting to schedule a mutually beneficial time and location. It's important to talk to the people that you want to include on your task force to find a time and a date that works for the most people. Again, you can kind of go through, you know, order of importance too, with like the people that you feel should be a part of your core team. You should really try to make sure that you find a time and location that works best for them. Some of the ad hoc members, maybe they won't be able to make it to the first meeting, but again, if you keep them updated with some notes, which we'll talk about a little bit later in my presentation, that should be fine. You also want to invite someone from the highest office possible in your hospital. So that's definitely like nursing leadership, physician leadership, but also hospital administration. And you'd want to send a formal request to attend. you'll want those leaders on board when you're trying to make change in maternity care at your hospital. You'll also want to, of course, prepare an agenda and your presentation materials before the first meeting. And you'll want to include the agenda in any emails, reminders you send to your team to remind them to attend. So, first you'll want to send an email saying, a few weeks beforehand, save the date, save the time for our meeting. And then I always think it's really great to send an additional reminder either the day before the meeting or, like the morning of the day of the meeting, just to say, just a reminder, everyone, we have a meeting today. I hope you all can be there. Again, this is like the location we're meeting at. Here's the time. It's really great, too, if your team uses like calendar invites, like if your hospital uses Outlook for their emails, send an Outlook calendar invite. So, they'll have an event in their calendar that will pop up and remind them. Okay, so for that first meeting, you'll want to set the agenda. And you'll just want to kind of lay the groundwork for your entire task force in this meeting. So you want to start with introductions. People probably, will have met everyone in the room or at least know them, know their face. But it's just great to kind of formally introduce yourself, talk about your role at your hospital. You'll also want to review your project goals and your resources. And so, you'll want to review some of the like what it takes to become baby-friendly if that's your overall goal, or any of the 10 steps to successful breastfeeding that, you wish to achieve as your hospital. And you can also review resources. I think there are a lot of helpful resources on the Baby-Friendly USA website. They outline the 10 steps to successful breastfeeding. And then there's also resources just from different like physician groups and nursing groups on the benefits of breastfeeding if you still need to convince your team that breastfeeding and these evidence-based maternity care practices are important to adopt. You really want to invite input and share ownership at this time. So you want to hear from all the members of your team. You want to know what they feel about these changes that you're going to make. And you want to make sure that you bring everyone on board so that they feel invested in your task force and in the changes that you're trying to make. The next step will be establishing operating norms. So you want to establish what's going to happen during your task force meetings and also in the times between your task force meetings. So, you'll want to establish, at each task force meeting, we're going to review our goals at the beginning of the meeting, and then we will review whatever work we've done in the past month, and we're going to set goals for what we want to accomplish in the months to come. And you'll also want to begin articulating these short, mid, and long-term goals. And finally, you just want to agree to meet again. And so you'll want to set up, that time and the place. So these are the materials you'll want to share with your team. So these are the resources that you can share with them. So you have the Baby-Friendly USA, the guidelines and evaluation criteria. These list all the 10 steps to successful breastfeeding. And you'll also want to go over the 10 steps to successful breastfeeding in detail with your team. And share, a detailed paper version of them, so that people can read, they have that as a resource. So when you're talking about skin to skin, a few meetings past the introductory task force meeting, they can refer back to that and say, and know exactly what, you mean by skin to skin when you refer to that. And they can have it is a very specific definition, that also applies to things like rooming in. Okay, so just a little bit more about setting goals. you'll want to describe, first you want to describe your current maternity practices at your hospital. I know even though that everyone is currently working at your hospital, they don't really know what's going on in everyone's specific role. So your pediatricians might not know exactly what's going on in labor and delivery. So it's important to just review what is happening at your hospital so that you are all on the same page. You'll also want to review the 10 steps to successful breastfeeding and the baby-friendly hospital initiative criteria. And again, I think it's really important just to give people those resources so that they can review them in detail on their own, because they are quite detailed at times. You'll also want to identify your long-term goal. So this can be 3 years out. So for a lot of the hospitals that we're working with, that long-term goal is baby-friendly designation. And so you'll want to have a specific goal of, by January like 2017 or, like August 2017, our hospital will achieve baby-friendly designation. And you'll also want to identify some mid-range goals. So looking 1 year out, what do you hope to achieve? And you will want to have, a specific statement of, by September 2016, 100% of our nursing staff will have achieved their 20 hours of education. Or, by September 2016, at least 80% of our patients delivering vaginally will have skin-to-skin with their infants. And then you'll want to identify your short-term goals and priorities. So these are things that you can accomplish in a month. So by your next task force meeting, these are the specific tasks that you hope to accomplish. It might be registering with Baby Friendly USA, or it might be, sending out a link to an educational, some education for your physicians. And you want to assign those tasks to individuals on your task force so that people are accountable. So when you meet next month, you can say, Sarah, you were supposed to email the link out to the physicians. How did that go? Did you hear back from any of them? Did they do any of their education? And again, when you're assigning tasks like these, the subcommittees that you create, they can be assigned to each goal, which is really great, because I think when you kind of divide and conquer these tasks, things are more easily accomplished. Okay, again, just to kind of reiterate what's already been said, this is a list of things that every meeting should include. So you need to set a standing time and place each month to meet. And so, for example, this could be like the first Monday of every month at noon. Your task force knows that they're meeting. Having a standing time is really helpful because you don't have to spend time during your meetings trying to figure out when you're going to hold the next meeting. It's just a standard day, and so that decision is already made for you. You also want to make sure to send out meeting reminders with the agendas before every before every task force meeting. And so this is really helpful because you can encourage your ad hoc team members to attend when the agenda items apply to them. And so as the baby-friendly task force lead or whoever is assigned to send out these reminders, you can either personally invite people and ask them to make sure that they attend, or you can send out the agenda and just encourage people to review it and make sure they attend if they are interested in the topics you're going to be covering. You also want to assign someone to take meeting minutes or notes during your meetings. And this doesn't necessarily have to be, the baby-friendly task force lead. Sometimes it's even better if it's not the person leading the meeting, taking notes, because they'll have more time to write things down than somebody who's trying to lead the meeting and figure out who's talking and move things along. So after the meeting, it's important to type up these minutes and send them out to the entire task force team, so that even those who aren't able to attend the meeting in person, they can still stay updated, and they can read about what the task force has accomplished and what they've decided and what you all are working on in the next month. And last but not least, you really want to share your results and your successes. So it's great to share them within your task force, but it's also really great to share them just throughout your hospital, your maternity unit, and the hospital at large. So this can be something like sending out, an email update to all of the maternity nursing staff, or having a bulletin board in your hospital where you post pictures or messages about what your team is doing and the changes that you're making. You also want to make sure with your task force to try to sustain your enthusiasm. So you can do this through food and drink at your meetings, so people will be excited to attend your meeting, the task force meeting every month. You really want to value every participant's role as well. And so this can be something like valuing their time, like making sure people know when they really need to be at a task force meeting, and they also know when they don't have to be at a task force meeting. So you don't have task force members sitting there bored because what you're talking about doesn't really apply to their practice or to them. And you want to celebrate everyone's role in maternity in your hospital and also on your task force. You want to make it easy to attend and participate. So having that standing meeting time and place is a way to make it easy to remember to attend and participate, and also sending those email reminders to remind them when their meetings are. That's another easy way to attend and participate. You don't have to be a part of some secret club where you whisper, the meeting time and place. And you want to offer people opportunities to shine. So I think that really happens when you do break up the subcommittees and give people, certain roles and goals to accomplish. You also want to highlight your forward momentum and to keep it fun. So it's great. I think bulletin boards are great to kind of show what you're accomplishing. You can do things like maybe order some fun small gifts to give to nursing staff as they complete their education, or to doctors as they complete education, to kind of keep it fun. A lot of hospitals plan some fun like events and parties. They'll have like a movie night where they show a documentary about birth. And then, or like the golden hour, so that can keep it fun. You can offer popcorn and cookies. And you also, want to consider purpose-driven leadership. So this is making sure that the leadership that's leading the task force, they know what the purpose is for the task force and for making change. So you want the leadership of your task force to understand that you're making change not for the sake of making change, but because you want to have the best maternity care for your patients, and you want to ensure patient safety. And you can do so by adopting the Practices Baby Friendly Hospital initiative. So we have a team on the line from St. Anne, and they've had a lot of success with their task force. And we wanted to give them a chance to share with you all how they run their task force, how they break up different tasks to work on, and some of the fun ways that they've been working together. So is the team from St. Anne's on? I can also, I may have muted them in my, so I'm going to unmute people now. If you can just remute yourself if you don't want to be muted. Is the team from St. Anne's able
Can you hear
to
me?
speak now? Hi,
Hey,
yes.
Hey, it's Crystal and Kelly from St. Anne's.
Hi. Great. Would you like to share at this point how your task force works?
Yeah, so a few things. We started our task force at the beginning of the year. The biggest challenge was trying to not have a huge number of people so we could try to stay like, hold people accountable and stay organized, but we did want to have the right people on the force. So we started with a staff nurse from the mother-baby unit and from L&D, lactation, our director, which is Kelly, we have an OB physician, our physician champion, and we have a peds physician. We also have a representative from surgery. We have 3 representatives from our OB clinic. We have we use our electronic medical record that we use as Epic, so we actually have our Epic person on our committee as well. We have somebody from pre-admit, and we have one of the CRNAs from anesthesia. And then probably the biggest, I highly recommend having someone from marketing on your task force, because she has been like a huge, huge asset to us over the past year. So we do meet monthly. I wish we did have like a set schedule, but we really don't. I normally just try to send out an appointment like 2 weeks prior, whenever we find a day that we think will work for most people. Everybody can't make every meeting. But we meet monthly. We always have a very structured agenda to try to stay on topic, because it's very easy for like somebody to really want to talk about something, and then we just end up not going through the things that we needed to talk about. So definitely a structured agenda. Y'all did make a good point today with typing up the minutes and sending it out to everybody. We haven't been doing that, so I think we're going to start doing that, just to keep everybody what's going on, instead of one by one catching everybody up. But it's really been nice, because some things that we don't think of, they do think of, and it's important to them, and we kind of overlooked it. Of course, like my director and I, we end up doing a lot of the stuff, but marketing does a ton of stuff for us. The clinics have really tried to revamp their prenatal education based off the stuff that we're giving out in the hospital, and we're all using the Cofective education. So it really helps, because it's like a continuity of care. And then our physicians, like I said, we do have an OB physician and a peds physician, and they always have something extra to bring to the table. We recently started, after the Mother-Baby Summit in Baton Rouge, we started, we were doing skin-to-skin in the OR. We were interrupting that skin-to-skin to move the mom to a different bed. But after the summit, they said, we can do, some people are doing transfers with baby on mom. So we actually started doing that here. So it was really important for like that anesthesia to be on this task force, for us to talk through it and come up with like a operational standard on how we were going to go about that. And we've been doing it now for like over a month, and it's been really, really wonderful, with uninterrupted skin-to-skin from time of birth for our C-section moms until they're done with their feedings. And then same thing, like when we rolled out no pacifiers, marketing was really quick to, get the flyer out there and make sure we had everything we needed to be successful. We did that August 1st. And then Epic is our electronic medical record representative, which is our Epic person. They help us with tons of stuff. Like they need, right now we're doing a mother-baby build, and they definitely need to be in the know of what's going on. So think outside of like the nursing and the care providers, and definitely try to get like that Epic person and the marketing person. Another person that I do wish we did have on our force was a patient. Which a lot of us who sit on the force have had babies at our hospital, so we can kind of see on that aspect, but it really would be nice to have a mom who can come sit in on that side and give us, what we could do better. We're always, you know, what they thought worked and what didn't work, and just try to see like their side of it. I think they would have something to bring to the table. So that is a goal of ours, to get a mom that could come and sit on our task force.
Thank you, guys. So if no one has, if you don't have anything else to add, St. Anne, we will open it up to questions from other people on the webinar. So if you have any questions for Emily, for me, or for the team at St. Anne, we will open it up. I'll unmute everyone again, and we'll open this up for questions now.
I'd also love to hear if there was anything in here that really resonated for you, or any ideas that you have that maybe we didn't mention.
Hi, this is Jennifer Nelson at CDC, and I just wanted to go back to the people at St. Anne and ask them to elaborate a little bit on their EPIC EMR and kind of what components were included in that mother-baby module. Thank you.
So recently, the whole Oshner system, we've added like a mother separation tab to our workflow, so the nurses are so it's easier to run reports. So we have like immediate skin to skin, delayed skin to skin, mother-baby separation, the reason for separation. So it's just allowed us to run reports easier, see exactly what's going on, hold the nurses accountable, and make their charting easier, because we were definitely having issues with, I think the nurses were doing what they were supposed to do, but they weren't getting credit for it because there wasn't a clear spot in the EMR. So we have really, we've really been able to design EPIC to meet the needs of Baby Friendly.
Jennifer, this is Emily, and I just want to add to that by saying that all of our hospitals, one of the very first things that we do is have a data collection and documentation webinar where we provide them with exactly what the measures need to be and help have further understanding of exactly what we're talking about when we say skin to skin, for example, that it's not just what we call drive-by skin to skin. It's really, you know, immediately initiating and remaining through the first breastfeeding, or at least 1 hour of exclusively formula feeding, and also making sure that if there's a delay or an interruption, early cessation, that we understand whether it was clinically indicated, maternally driven after counseling, or done for some other routine indication. So we provide a comprehensive user's guide to adjusting the documentation template so that they have the accurate measurements, but then also they're easy to dichotomize the measures and just get their numbers in a quick report rather than having to search for text.
And this is Anne. I just want to chip in here. Emily has done a great deal of that work, and she does, these great meetings and goes and does site visits with the hospitals and helps you guys to figure out your records. Obviously, not all of you have electronic. Some of you still are on paper. But certainly we have a real expertise with Emily in the electronic medical record for those of people who need that help. So if you haven't fully taken advantage of that, guys, those are the hospitals on here that are CHAMPS hospitals, do hook up with Emily and make sure that you take advantage of that. And I have to say that we did a conference in Mississippi on Friday last week. We were in Mississippi all week, many of us. And the hospitals that stood up there on the stage and presented on their practices and their especially skin to skin was what they were talking about. It was very gratifying, and I wish Emily had actually been in that session too. That they were saying, we really didn't feel like we wanted to collect all these data, but when we did start to collect them, it really taught us a lot about what was happening in our hospital, and they were really happy. And those of you who are in CHAMPS or maybe considering joining CHAMPS in the future, we don't ask you to do any extraneous data collection. It's just the data for any data that you collect for us will be what you collect for Baby Friendly as well. So it's just basic rooming in skin to skin and breastfeeding rates. So it's really a big part of the program, and we do thank all of those of you who are sending in those data, because we know it's not easy. Even though we don't ask for a massive amount, we know it takes a lot of work.
And Ochsner system especially really did a great job by doing it as a system. Those of you who are also part of a broader healthcare system, if you are able to do it with your sister hospitals sort of as one big change, it definitely helps to reduce the burden on any one group, which is sort of an example of working as a team, that sometimes your team may be even broader than just your own hospital.
Yeah, and I don't know if anyone's on from the Baptist system in Mississippi, but we were very excited that the Baptist system's going to do that as a group as well, and we're facilitating that this week. So it really does help. If any of you are, we've worked with individual hospitals to identify other people in the system. So we have more than one hospital in a system. We're proactively trying to connect you. But if there are any of you that are groups that are with us, do team up, not only for the electronic medical record, but for things like policy. It can save you a lot of steps and a lot of time if you all get together and create one, which, again, you guys at Ochsner are doing for policy. I know that.
So thanks, Jennifer, for your question about data collection. Are any of the other callers or WebEx users interested in sharing ideas or questions that you may have? Are there any community members on the line who've been part of a facility breastfeeding task force? And if so, what's that been like for you?
So this is one thing that we ought to work on, guys, because we all for the champs thing, and I'm taking the silence of that as being that we don't have community members in the task forces. The C in champs is for community. So one opportunity that you'll have to meet up with some of the community people is when we have the conferences. We've got one coming up in October for the New Orleans and Texas hospitals, and then we have one for the CHAMPS hospitals in those states, and then we have one in November for Mississippi and Southern Tennessee hospitals. And please go up to Kim and talk to Kim. We have other people. We have people coming in from La Leche League, from the state task forces, from the WIC offices. Tawanda at the Mississippi WIC office in the Delta. There is a fabulous connection for some of you to have people from WIC coming and working with you. And indeed, last week when we went to 5 different hospitals site visiting in the Delta area, WIC came with us. Tawanda came to all of them, and someone from WIC came to all of them. So there are ways to do that. And if you haven't been able to engage with a mom, I do think that you could reach out to your WIC office. We want to know that you're connecting with the WIC office. Hopefully you've already spoken with our community contact, Roger, who's been trying to link up the community and the hospitals, and get WIC to help you. And if WIC, first of all, get WIC to come to your meetings if you possibly can. And then you don't have to just be WIC, get WIC to find some moms for you that will come to your meetings as well. Because there are ways, even if, there may not be people that you can just grab from your hospital that had a baby there yesterday, but I'm quite sure that WIC is working with moms who've had babies there now and previously, and they can help link you up.
I don't see her on the line today, but I do know that Leanne at why am I not thinking of the name? Hancock, in Mississippi. She has had a really interesting experience with, she identified a patient who the father actually said to her, we had our baby here a few years ago, and we just had another baby now, and it's amazing to see what a different experience this is. We really love this whole skin-to-skin thing. Why weren't you doing that before? And so she's engaged with that family. It's just a real natural connection to try to find out more about how they felt about the new experience compared to the old. It's really helpful when you have people who compare that way. So, it may be good to involve that family as an example for a year or so, and then look for another one as they get further on and they've got a toddler who's a little harder. Maybe they can't bring them with them in the sling or something. Engage another family who can speak to what their experience has been like more recently. And it's really helpful. You won't always love the feedback that you get, but either way, I promise you'll learn from it.
And I see Linda McGrath on here, and Linda's one of the big La Leche League leaders in Mississippi and has lots of connections too. So, tie in with all the different groups. There's WIC, there's La Leche League, there's your task force, your statewide task force. They're definitely going to be able to get representatives between them. And it'll be good for you to link in with those groups as well as you're searching for people to join.
Again, I'll re-emphasize what Laura was saying, the importance of a time of day and a location. You know, if you have your meetings in a conference room in the NICU, it may be difficult for community members to be able to gain access, or perhaps you need to do some infection control and maybe you don't want lots of people coming into the NICU. Similarly, you know, you want it to be at a place where community members, prenatal clinic members coming from outside can easily park and get to, where they're comfortable, and at a time that's going to be feasible. You know, if you do your meeting at the start of office hours, you're probably never going to get physicians who can come. So, you know, you really want to make a great effort from the very beginning and then occasionally throughout the life of your task force. Make sure that you're checking in about the feasibility of participation. Don't just take regular attendance to mean that it is feasible. Really check in and make sure that, you know, people aren't struggling unnecessarily to be able to participate. And of course, for moms, have it in a safe place where they can bring their babies and encourage them to keep their babies with them. We want that mother-baby togetherness, and, you know, some squeaks and sounds here and there is part of the sweetness of all of it.
And, you know, it's amazing. I've worked with at least 2 hospitals where right towards the end of this whole process, they've been complaining, for example, our obstetricians never came or our pediatricians never came. And they'd had their meeting, you know, at the same time as a standing meeting for the OB team. And it was like 2.5 years on and no one on either side had ever identified. You know, the OBs were like, well, we can't go. And it was felt like, well, have they never, like, spoken to each other? The OBs are complaining they can't go and the task force complaining they never come. And they both got their meetings at exactly the same time every month. So it sounds really obvious to say that, but we are saying it because you can overlook it sometimes, and it definitely has happened. And I've got direct experience working with sites where that's happened.
This is Jan Waddell from St. Tammany Parish Hospital. And
Hi, Jan.
Hi, how are y'all? I finally figured out how to get both auditory and the visual. So I'm
well, good for you. We're glad you're on.
But we held our first task force meeting, and fortunately we had spoke with you all, and so we implemented a lot of this. We had a great success with attendance. We had I think 2 of our OBs, we had 1 of our pediatricians, we had 2 of our neonatologists, but the one thing that the nurses that had attended and I were talking about the other day that has kind of got me concerned is these physicians are really champions, and they say, you know, we support breastfeeding, but when we start talking, particularly with the pediatricians, about making rounds in the room, you know, when it you know, it's like we support breastfeeding, but if we have to change, you know, they didn't say they wouldn't, but they just kept coming up with so many different things that were roadblocks in their eyes to implementing that. So my solution was East Jefferson, who's our mentor through the COFECTIVE program. They did a wonderful presentation on their rooming in and such. And so we've asked them, which they generously said they would come, and patient at our one of our task force meetings in the future. But I just was a little discouraged because it seems like it's going to be just an uphill climb the whole way, even with to support breastfeeding.
Yeah. So John, don't be too worried. I mean, this, first of all, that's a really common problem. Like the specific problem that you've identified in terms of doctors not wanting to go into the rooms is very common. And it's not just necessarily doctors. You may be finding that some of your nurses are more comfortable doing the hearing screen in the nursery or the blood work in the nursery. So it's not just always one group. I think, you know, don't be discouraged. If you whittle away at all the other things, you will come to that, and the important thing is that you have them on your task force. This was the first meeting. You guys are all talking about it. So it's a really good, it's not anything that you should get discouraged about. We have hospitals, I know because I've worked with you already, and I know you're actually quite a long way on the other stuff, so you're actually, you're ways ahead of many other places when they start out already. So don't dwell too much on it. Make sure you guys are talking about it, and it is great. I know that East Jefferson is baby friendly, so any sort of help that they will offer you, just take it. That's fabulous. And again, you know, some of these webinars and sessions at the, you know, if you can get a doctor to come to the learning session in New Orleans, you know, they will meet other people who've implemented this rooming in. In fact, we've got a doctor talking about rooming in Mississippi, but we could probably do, you know, a webinar. It's a case of really engaging them and getting them to come to some of the things that we offer, or just to chip away at the other practices until, if that's the only thing left for rooming in and all the other care has been done in the room, you know, eventually that too will fall, because it has everywhere else. Emily, I'm sorry, did you want to say something?
I would love to, actually. Dan, thank you so much for sharing that. I think, you know, in presenting the best practices, sometimes it's easy to overlook the things that can feel really discouraging, and I really appreciate you bringing that up, because certainly it can feel really disappointing when you come up against, you know, sort of the yes, but. Yes, I support breastfeeding, but I still want all of my babies to leave with a supplement, or I support rooming in, but I need to do my rounds in the nursery where I have great lighting and all of the equipment that I need. In quality improvement, we have a phrase, and that phrase is, we are going to experiment our way through change and learn our way to improvement. And basically what that means is that we need to adopt a curious attitude where we say, yeah, absolutely. So I see that we all have the same intention. We're very much on the same page with where we need to be. You establish that common ground. And I hear that there are barriers, which is exactly why we're involved in a project like CHAMPS. If there were not barriers, everybody would be doing this, right? Every hospital would be doing the rooming in and the skin to skin. But there are barriers, both in attitude and in workflow and staffing, in the availability of equipment. So that's a great opportunity to say, yes, and you know what, let's put this on the agenda for next time. Let's talk about all of the routine causes for separation that we have in our facility, and then we can, as part of our improvement journey in rooming in, chip away at each of those by experimenting to see what works. So as Ann said, you're going to find other barriers to rooming in as well, and we can apply this to every other step for all of the others of you on the line today. But really take that as an opportunity to say, great, yeah, let's hear all these barriers, because we need to know what the barriers are to find our solutions. And then we are going to experiment our way to change and learn our way to improvement by being curious and starting out small. At the upcoming learning session, we're going to have a session on quality improvement method called PDSA, which is a way of doing a very small experiment, meaning like one patient, one nurse, one doctor, one day, in order to see if an idea you have might work. So for example, Dan, in your suggestion here, maybe you have an idea for how you can make physician rounds in the room feasible. With one patient, one day, with one physician who's willing, you go and you try it in the way that you think will work. And it may be that the method you had is a disaster, right? They don't get their assessment done, the mom doesn't like it, the baby screams through the whole thing, they don't have the equipment, it took too long. Well, you're going to figure out what all the problems were, you're going to revise, and you're going to try again. And you only increase the scale as it seems more and more likely that it's working. At the same time that you're increasing the scale, you're increasing people's belief that that change is actually the improvement that they need. So rather than saying starting tomorrow, everybody, you have to do it this way, you're saying starting tomorrow, one person is going to try to start working with one mom to figure out whether this particular change might get us there in the long run. So it helps to just start out from that smaller step, and we'll learn about that process of experimentation together.
Well, one thing that we are in the process of doing is we're taking just 2 infants per week for the next couple of weeks until we meet again, and trying to track their movement when they leave the mothers, and come into the nursery, and as far as the reason why, to really determine what's the primary reason for separation. You know, I have a suspicion that it's and as you all said, it's not just physician rounding, but other things also. So I think you're right in starting out small and trying to figure it out from there.
Great. Yes, I'm so glad to hear that that's what you're doing. And I actually have a little worksheet that you can use to track those separations that I can email to you. And the rest of you, if you're interested in having that worksheet to track separations, just chat your name into the box over on the right, and I'll be happy to send that to you. But it is, our hour is up. It always goes by so fast. So, Laura, you want to close us out?
Yeah, mention the upcoming webinars as well, Laura, if you've got them handy.
Sure. So I can direct you. So this is the first in our Wednesday webinar series that we're doing in collaboration with the Mississippi Department of Health. And these webinars are really open to the public. So whether you're in a CHAMPS hospital, if you're a community member, or if you're a hospital who is, you know, interested in the work that CHAMPS is doing, you're welcome to attend. And you can register for these conferences on our website. And our website is www.champsbreastfeed.org, and then you can go to the little tab that says meetings and webinars.
And I just want to add one thing, Laura. We just set up, and we haven't publicized it yet, but in October we will have one additional webinar, which is going to be CHAMPS and Blue Cross Blue Shield Mississippi is joining us. Many of you may have heard the exciting news that Blue Cross Blue Shield Mississippi is working to get all the Mississippi hospitals baby-friendly. They will be working with us on that webinar, and we're going to have Baby Friendly USA themselves present that webinar, and they're going to be talking about the whole process and what baby-friendly is from the perspective of the organization which designates and comes out and does the assessment. So that is to look out for. We'll be sending out a notice about that, and it'll be in late October.
Great, thanks, Dan.
Okay.
Oh, no problem. So yeah, so anytime, you know, all of these webinars are posted on our website along with